Good morning, guys. We are going to start today's registrar teaching. The topic is on multimodal analgesia. It's 10:30, and we will have some registrars joining us from Liverpool, about two university hospitals, Royal Liverpool University Hospital and Aintree University Hospital. In a minute, I will actually start sharing my screen. So we're talking about multimodal analgesia in anesthesia practice. I'll be not only discussing the theoretical background to multimodal analgesia, I will also go through some practical aspects. I'm just waiting for a few of the registrars to join me. And once they are with us, we will start the teaching. Maybe some of them might be actually getting their coffee to start off. So I'll start off in a minute or so. I am live transmitting it to YouTube, my YouTube channel. So those who cannot attend can also listen to this lecture later on. It's 3 minutes past the actual starting time. It normally starts at 10:30. So I'm going to start off. So this is a very recent conversation with one of my concerned colleague. And we were doing a orthopedic case, and he came to me and asked me, he says, hey, why are you actually giving this patient dexamethasone and diclofenac and paracetamol? Wouldn't your block just do the job? The answer is yes, it can do the job, but pain is just not from the surgical side. Okay. And there are people who say, why polypharmacy? They think multimodal analgesia is polypharmacy, but that's not true. Polypharmacy just means that you are actually giving drugs without actually understanding that they've got side effects, and the side effects can be cumulative. Whereas multimodal analgesia is different, which I will actually define in a minute. We are only trying to use their advantages and reduce the side effects of individual drugs. So when I was actually posed this question, so why multimodal analgesia? And my simple question was, do you really understand pain and pain pathway? And this does raise an alarm. Okay. So Baylor College of Medicine actually used this acronym ALARM to, make people aware of the use of multimodal analgesia. So anesthesia, it could be general anesthesia, local anesthesia, or regional anesthesia. And M here stands for multimodal analgesia. So we need to actually combine multimodal analgesia, irrespective of whether you're using a regional anesthesia technique or general anesthesia technique. But obviously, it needs to be individualized. So this is what we are traditionally taught. This is a triangle where it says anesthesia is basically, amnesia or hypnosis, that is inducing anesthesia, giving analgesics, providing muscle relaxants. And the analgesia is was purely opioid based. So this was an opioid based anesthesia. But then we know that opiates are not a solution to everything, not to all problems. Okay, they can be good analgesics. And we all know all these side effects of opioids, and not as much in UK, but in the US, opioid epidemic is actually a big thing. And that's probably because they tend to prescribe opioids for a longer duration of time than we do in the UK. So this is an interesting observation or a statement from Cousins, Power and Smith, published in 2000. Say acute post-op, this is about acute post-operative pain. It says it remains a common misconception among clinicians that acute post-operative pain is a transient condition involving physiological nociceptive stimulation with a variable affective component that differs markedly in its pathophysiology basis from chronic pain syndromes. So people think that, chronic pain is an entity on its own. It's not. Every chronic pain patient has had acute pain sometime in their life. So if we look at the chemical mediators that are actually released in acute pain, they're no different from chronic pain. So what happens when there is a trauma or there is a surgical insult? The nociceptors, they pick up the stimuli at a higher harmful intensity. Immune mediators and chemical mediators are released. These chemical mediators, they either sensitize or directly activate the nociceptors. And this is what can lead to hyperalgesia or allodynia. Some of these immune mediators like bradykinins, 5-hydroxytryptamine or serotonin, prostaglandin, potassium, histamine released from mast cells. Now, these can sensitize the nociceptors, or they can activate them directly. And some of the substances like the CGRP, that is this calcitonin gene-related peptide, causes vasodilation. Substance P causes mast cell activation and release of histamine. So these causes, vasodilation and edema. And this edema formation then also initiate the release of neurokinins, that is bradykinin 1 and 2. The serotonin is usually released from the platelets because whenever we have surgical trauma, there's going to be a bit of bleeding, platelets are activated. So they also release serotonin, and these two activate the nociceptors. So this is the other diagram which shows there is vasodilation because substance P, CGRP, bradykinin, that is NK is neurokinin A, or bradykinin 1 and 2. And there is a nociceptor sensitization, which can lead to hyperalgesia and allodynia. So hyperalgesia obviously is the even a little bit of your pain or whatever the stimulus is causes severe pain, which is actually not proportional to the stimuli. And allodynia is that the sensation which shouldn't cause pain will cause pain. So those things actually happen in these cases. We all know from the definition of pain or tissue trauma not only lead to physical, but it also leads to cognitive and emotional discomfort. And we also know that if the postoperative pain is unrelieved, it can lead to clinical and psychological changes, which can cause increase in morbidity and mortality. There are costs involved, and the length of stay might be increased. So the patient's cost for the hospital increases. And obviously, there is decrease in quality of life. Patient can't enjoy what they do. So how big is that this problem, the acute postoperative pain? How big is the problem? This has been studied extensively, and it is still said that despite all the advances, there is 3 out of 4 patients who wake up with pain. Now that's pretty significant. And 80% of these patients have moderate to severe pain. So just not mild, it's moderate to severe pain. Again, very significant. So in 2003, Applebaum actually did this study looking at acute postoperative pain, and he actually found the same thing as moderate. So most patients, that is 80% of patients, actually had moderate to severe pain in the recovery. Then again, there's 4 years later, there was another study on acute pain by Gan TJ, and they actually found that 86% of the patients experienced pain in the postoperative period. And 75% of this is moderate to extreme pain. So again, it was around 80% in the previous state, it's 75%, so not much of pain. And 74% of these patients still had pain and after the discharge from the hospital, not just from the recovery, from the hospital. Okay. So this postoperative pain is persisting, so it becomes persistent postoperative pain, and it does impact patient lives. Like I said, it does increase hospital stay, and so increases the cost. And there are actually, we have done studies. For example, we did studies on shoulder tip pain and looked at readmissions, and then that's how we changed our protocols. So, one second, there's someone who need to be admitted. And so there is obviously an increase. Again, readmission will increase the cost of in the healthcare system, and there is obviously a decrease in the quality of life for patients. They impair physical function. There is decreased functional recovery, increased complication. There's impaired sleep for the patient, and there is multiple publications on that how acute pain impacts the lives of patients. And it has been seen that inadequate acute pain management can lead to progression to chronic pain in almost 50% of the patients. So coming back to pain and pain pathways, I mean, all of you would have studied these during your the exams in primary as well as final FRCA. So basically, it starts as there is an injury or surgical insult. There's transduction, that is activation of nociceptors, and this leads to depolarization of the nerve endings. So there's transmission of pain, And there is postsynaptic depolarization of dorsal horn. So the neurons are activated in the central pain pathways, and you can actually see there are actually certain neurotransmitters. So we talked about substance P. There's glutamate, magnesium is involved, Nmda receptors. Nmda receptors are normally activated when there is a constant activation. That is, if you don't treat acute pain, then the Nmda receptors actually come into it. And then you can see there's magnesium sulfate is important part of the Nmda receptors. And if this persists, and then you can have central sensitization. So there is peripheral sensitization happening because of release of all these mediators we talked about. And if this persists, then there is changes in the dorsal horn leading to central sensitization, which leads to hyperalgesia and allodynia. And this is the ascending pathway, and so there is transmission of this pain through the spinal system, spinothalamic tract, and then it passes through the brainstem reticular formation and periaqueductal gray, which is very important. And then there's projection to the thalamus and the postcentral gyrus. So there is central perception of pain in the thalamus and the higher centers. And then there is modulation. Modulation occurs through the descending pathway. And all of you know about the gate control theory, where A beta fibers are actually involved, higher centers are involved. So there is also modulation of pain also occurs. But this probably won't happen in patients who are asleep, who have been given general anesthesia. And I talked briefly about central sensitization, which can happen at the dorsal horn, but the peripheral sensitization is equally important to understand. And so, like I said, when the nociceptors are activated, they pick up stimuli at a higher harmful intensity. Okay, so there's high threshold receptors. And these are converted to low threshold nociceptors. And this happens because of the inflammation which is happening, which is activation of sympathetic afferents, the release of this sensitizing soup. We talked about hardinase, norepinephrine, bradykinin, histamine, potassium, interleukin, and serotonin, neuropeptides, leukotrienes. So all these soup. So these are not only seen in the chronic pain, these are actually also seen in the acute pain. So here the receptors which are activated by high threshold now become low threshold receptor. That means the stimulus which wouldn't cause you pain will actually start causing pain. So peripheral sensitization is there. So some consequences of pain I talked about in general about pain, but what is happening at the cellular levels? So tissue injury occurs, there's release of retinoic acid, so that's why we use COX-2 inhibitors, prostaglandin synthesis occur, nociceptor activation, peripheral sensitization, which I talked about, or primary hyperalgesia occurs, and acute pain happens. But if this acute pain is intense and prolonged, okay, so it's persistent, then you get central sensitization. Central system comes into play. There's an Nmda receptor activation, which involves calcium, magnesium. Okay, so secondary hyperalgesia occur. There's upregulation of COX-2 inhibitors and nitric oxide synthetase. Prostaglandin synthesis and cannabinoid breakdown occurs. So there is neural and glial remodeling in the central nervous system, and there is long-term potentiation. So it's like a vicious cycle happening. And this actually leads to the production of or progression to the chronic pain. So if you don't treat acute pain, not only intraoperatively, but also in the immediate, doesn't matter. We can never be 100% perfect. But if patient wakes up in pain and treated, we need to be very aggressive in managing acute pain. No patient should be discharged from the recovery with pain, any kind of pain. Okay. So coming to the role of multimodal therapy or multimodal analgesia, so it's been described as a synchronous administration of 2 or more agents or approaches. So it's not just pharmacological, it could be pharmacological and like nerve blocks or regional techniques. And each of them has got a distinct mechanism of action. So whole idea is to target different pathways, use synergism of the multiple agents, and which will allow us to reduce the doses of the individual agents we use for managing pain, and thus reduce the risk of adverse effects. So that's the rationale behind the multimodal analgesia. There were certain key recommendations made, and obviously they say that we should be using regional anesthesia, whether it's epidural, catheters, intrathecal opioids, but also, you need to actually use PCA wherever there is going to be a long duration of pain. So if the patient is going to have pain in the post-operative period after your blocks have worn off, maybe PCA should be actually be used. And the other thing is that if this is mostly for post-operative pain, patients should receive round-the-clock regimen. So it's not just PRN. It should be around the clock, and they should include non-steroidal anti-inflammatories, COX-2 inhibitors or COX, either of them, along with the paracetamol. And the regimen should be administered to optimize the efficacy and reduce the risk of adverse events. So don't have higher doses. You need to know where the doses need to be reduced in patients. If, for example, patient has got renal failure or they got liver problems, they need to reduce the paracetamol dosage in those patients. Okay, and the choice of medication dose, the route you administer it, and the duration of the therapy. So how long you're going to continue that? At what stage will you actually allow it from becoming around the clock to PRN? That should be individualized. So when we are dealing with the management of pain, we need to look at the patient factors. Okay, so there are patient factors, there are factors, surgical factors, anesthesia factors. And there are genetics is involved. Some patients are more sensitive to pain than others. And there is obviously age. The elderly don't feel pain as much as youngsters. Okay, there is obviously memory involved. So experience, bad experience in the past can actually affect it. Mental state of a patient, the anxious patients are known to progress to chronic pain. So these patients need to be actually managed a slightly different way. The activity is equally important if the patient is being active. So rehabilitation is part of that. So it's a teamwork. Managing pain is a teamwork. So we need to know about the patients. We need to know what surgeons are going to do, how much tissue damage they are going to cause. So a minor surgery doesn't require as much analgesia as for example, a knee arthroplasty or a hip arthroplasty. Nurses are important. They need to have clear instructions for management of post-operative pain, round the clock management of the analgesics if the patient can't take orally, providing a PCA or IM injections. Okay, we are obviously involved in designing the analgesia program for these patients, and then there are physiotherapists and psychotherapists. So it's a whole team effort. So we already discussed about the pain pathway, and we can actually target these pain pathways at different levels. So we can look at the transduction phase. So there is the peripheral nociceptors where transduction occur. So, you can have oral analgesics, which can be given to patients even before they come to theaters. So, like, for example, we have low limb protocol at the Broad Green for orthopedic patients. So these patients are actually given oral analgesics, which includes gabapentinoid, which I've not included here. You could infiltrate local anesthetic at the site of operation, or you could actually give nerve blocks for preventing the transmission of pain. We can use single shot, or we can use catheters. Then we can actually also, have at modulation phase or at the spinal level, we can use local anesthetics alone or along with opioids. Alpha-2 agonist, which can be given intravenously, NMDA antagonist like magnesium sulfate and ketamine, and COX-2 inhibitors in non-steroidal. So these can also affect the modulation of pain. Now, perception of pain, opioids obviously are on the top of that, but I'll also look at the bottom. General anesthesia also prevent the perception of pain intraoperatively because patient can't perceive pain when they sleep, but we only look at the surrogates of pain like your heart rate and your blood pressure. But certain agents like your Nmda receptor antagonists, magnesium sulfate, ketamine work centrally, alpha-2 agonists work centrally, opiates work centrally. So these are all part of multimodal therapy. Ketamine, it's important. You have seen that when we are talking about the transduction of pain and modulation at this dorsal horn, glutamate is an important primary excitatory neurotransmitter. Nmda receptors are activated when there is a constant bombardment of this noxious stimulus, and that's where ketamine actually and magnesium sulfate comes in. Magnesium sulfate tend to block the channels, Nmda receptor channels. So ketamine and magnesium can not only act locally, they also act centrally. So there are peripheral actions of the ketamine. They target the Nmda receptors on peripheral afferent receptors and thus stop the signals going to the central nervous system. Central action are usually at high doses. That's what we don't use as part of multimodal analgesia. And we don't see the side effects of ketamine when we use it. So when we're using ketamine, we tend to use a bolus of 0.3 to 0.5 milligram per kg, and then use infusion of 0.1 to 0.5 milligram per kg per hour. On average, 0.2 to 0.25 milligram per kg per hour are used by most of us, and need to stop it at least 30 to 60 minutes before the end of the surgery. Gabapentinoids are normally given preoperatively. Gabapentinoids, you can use gabapentin 300 to 600 milligrams orally as single dose, or pregabalin 75 to 150 milligrams orally. So we have actually two regimens. So we have normal, and then we have reduced dose for elderly and patients who have renal dysfunction in our lower limb protocols. So these are important. You can actually continue gabapentinoids into the post-operative period if the patients are already on it, one thing. And second thing, if the patients are prone to chronic pain, so there are certain conditions which would actually you can continue into post-operative pain. Or patients who are opioid dependent, in those patients also gabapentinoids are an important part of the regimen. So we'll look at some multimodal analgesia in actual practice. This is my armamentarium for multimodal analgesia. I hardly use opiate-free anesthesia, so I tend to actually give nerve blocks to most patients. I used non-steroidal diclofenac that's available to us. In patients who can't give blocks, I use lidocaine infusion. Most patients get magnesium, paracetamol, dexamethasone, and some actually get low dose of alpha-2 agonist, that is clonidine. We don't have dextromethorphan, which is very costly. So I use around 30 to 50 micrograms of clonidine as well as parts. So let's go through an example. So say, for example, we got a patient who's having a hernia mesh repair. And so all of you understand the anatomy of the hernia. So there could be direct hernia or indirect hernia. The nerve involved are, which are seen on the right bottom end, iliohypogastric ilioinguinal nerves. And ilioinguinal also travels through along with the spermatic cord. And then there is also genital branch of genitofemoral nerve involved, which is seen on the top image. So all these nerves need to be blocked for hernia surgery. And if you look at the hernia surgery, there are various components of the hernia surgery. Okay. So we look at the top part. So there is ligation of hernia sac. The surgeon might, do neurectomy of so the nerves may be cut or nerves may be trapped. There is fixation of the mesh. People use different approaches. Some may do a primary repair, but most of the time there is a mesh repair, especially elderly patients. Then there are things like experience of the patient. Has he had a bad experience? Then there can be complications related to that's in the post-operative period. If there is seroma formation, we have introduced a foreign material. The mesh is tagged to the pubic tubercle, and that can cause periosteoitis. There can be inflammation of the spermatic cord causing orchitis. So there is a lot more going on in just a simple hernia surgery. And these nociceptors stimulation, nerve injury can lead to chronic pain development. So if you look at the analgesia plan, it can be very simple, where the surgeon might give local infiltration and do it under local itself. Or if you're doing under general anesthesia, we would do a usual induction of anesthesia, use multimodal analgesia. If you are not very sure of your block, you might want to use IV fentanyl and morphine. That's okay. A little bit of fentanyl and morphine is fine if you're not using too much of it. And the blocks need to be actually used before the surgery. It will obviously depend on your expertise. But also remember, in the post-operative period, make sure that you have written up for analgesia for breakthrough pain. And for the ward pain management, patient is prescribed regular oral analgesia. And when patient can't take orally because he can have nausea and vomiting from the drugs you've used, then patient need to be prescribed IM analgesics as well. So yes, we do all checks, we do monitoring, we have IV access, okay, and induce anesthesia, airway. Soon after that, the patient can have dexamethasone. We use 3.3 milligram per ml, and this is equivalent to 4 milligrams per ml of dexamethasone phosphate. And diclofenac, if there is no contraindication to it, need to be diluted in at least 20 ml to 100 ml of saline. Otherwise, it's very painful, causes phlebitis. And then you can actually do a block. You can do a classical hernia block, or you can use the Aschenberger point. This is where you go 5 centimeter cranially and then 5 centimeter posteriorly. At this point, this is like doing a sort of a low posterior tap block where both the ilioinguinal and iliohypogastric nerves are lying in the same plane. Works better. And you can do spermatic cord block if you know how to do it. You can do it with ultrasound, or you can ask the surgeon to just infiltrate the cord, spermatic cord. You can use magnesium sulfate. The maximum dose is 50 milligram per kg. And there is no evidence what is the exact dose. And it has been seen even low dose, 2 grams of magnesium sulfate probably works as good as 10 grams of magnesium sulfate. So there is no right or wrong dose. And it is a cell membrane stabilizer as well. And if you want to give give paracetamol, that is, if you've not actually given oral paracetamol in the ward, you need to check that this is within that. It's not within the 4 hours or 4 to 6 hours. So we can give IV paracetamol towards the end of the surgery. And the peak effect of paracetamol takes around 15 to 20 minutes. That's why you need to give it around 20 minutes before the surgery. Now, lidocaine can be used. So if you want to use it, then obviously the surgeon should not be using local infiltration, and you shouldn't be using a block, because then you can exceed the toxic limit of local anesthetic that would lead to local anesthetic systemic toxicity. So the dose used, so this can be used for long procedures as well, where you can't give epidural because patient is on antiplatelet drugs, or there is contraindication to actually doing spinal blocks. So lignocaine 1 to 1.5 milligram per kg bolus is used, and this is followed on average of 40 microgram per kg per minute. And you can just use 1.5 milligram per kg per hour infusion till the very end, and then just stop it. But if you want to carry it on into the post-operative period, then you need to reduce it to 0.5 to 1 milligram per minute at the end of the surgery. And this can continue for next 24 hours. Okay, so once you reach the day, post-op day 2, just stop it. So 24 hours is the duration which you can infuse lidocaine for post-operative period. And for the recovery, please don't forget post-op nausea and vomiting. Now, I have seen people actually using an ondansetron. Well, you need to actually read the guidelines. The first line of treatment is usually dexamethasone. So dexamethasone, not only it's an anti-inflammatory drug, it prevents post-op nausea and vomiting. It increases the duration of analgesia from your blocks. So it's got lots of great advantages. Okay. But if you have AFL score of more than 2, so I hope all of you understand what AFL score is, then you can actually use ondansetron. Use ondansetron at the end of the surgery. Don't use it at the beginning. For short cases, okay, but if you have long surgery, then use it at the end of surgery, not in the beginning of the surgery. So important to understand that, and also prescribe post-op, PONV treatment for post-operative period. So if you have already used ondansetron intraoperatively, it's no point actually prescribing or asking them to give ondansetron again. It need to be another group of drug, and that would be like cyclizine. So you can use cyclizine for that. Just this year in May 2021, there was a systematic review and meta-analysis of opioid-free anesthesia. And one of the interesting thing from this was that even a single dose of opioid can cause post-op nausea and vomiting. So if you are using, for example, say fentanyl 100 micrograms for induction and intubation of trachea, this is enough to induce nausea and vomiting in patients, especially high-risk patients like female patients and non-smokers. It will induce things. So not using opiates itself at all, or the opioid-free anesthesia, reduces the risk of post-op nausea and vomiting. So post-op interactions are important, and WHO says that the analgesia should be by the mouth, it should be preferred route, and be by the clock rather than on demand. And for drugs like paracetamol, it has been seen that oral 1 gram paracetamol works as well as 1 gram of IV paracetamol, which has higher cost. So if patients can take orally, we should try to actually put them on oral paracetamol rather than IV paracetamol. And it has been seen that combination of paracetamol with non-steroidals, that is, if there's no contraindication, works far better than paracetamol alone. So combination therapy is important. Now, there are fixed dose multimodal combination available. You can have paracetamol with tramadol, or you can actually have paracetamol with ibuprofen available. So, and these drugs, there is also ibuprofen with codeine available. So fixed dose multimodal combinations are pretty useful, and they are coming in vogue. And last thing, if you are actually going to prescribe non-steroidals in the post-operative period for a week or two, especially like for orthopedic patients, then please don't forget to prescribe them with PPIs. It does help in preventing complications, especially like gastric bleeds. We'll go into some practical aspects of anesthesia. Regional anesthesia is one of my areas of interest. And so having told you about the pharmacological methods of pain, I will actually go into what blocks can we use for different abdominal procedures. So say, for example, you're doing a laparoscopic cholecystectomies, and or ventral hernia or laparoscopic hernia, you need to understand where the incision is going to be or where the ports are going to be. So if you look at open surgery, it's a ventral hernia. It could be just at the umbilicus level, so something like a rectus sheath. But laparoscopic actually extend into around the umbilicus. Whereas if it is a robotic, the incision or the ports are only on one side, and that is depending on where they're operating. So know where your incision is going to be. The other things is the surgeons are going to use tacks. Now, these are very, very painful. They go into the muscle and cause severe somatic pain because they are actually tacked into the muscles. So these are the cause for severe pain. It's important to understand the anatomy. All of you know about rectus sheath and the tab, the transverse abdominis plane. So I'm not going to go into that. You also understand about the quadratus lumborum. So there are quadratus lumbar 1, 2, 3. There's so many different ways. I won't actually want to take into that. The posterior tab, where the transverse abdominis aponeurosis, let me actually get a pointer. Yeah. So that's the transverse abdominis aponeurosis. So depositing local anesthetic at that point is actually a posterior tab or quadratus lumborum block. That works equally well rather than actually going intramuscular and injecting a bowel quadratus lumbar posterior to I won't actually. You also need to remember that the nerves which actually travel in the transverse abdominis plane then actually travel above the posterior wall of the rectus abdominis. Okay, so you need to inject local anesthetic under the rectus abdominis, but above the posterior wall for the rectus sheath. Okay, so that's what the timelines actually are. Okay, so you actually depositing local anesthetic under the muscle, but above the posterior rectus sheath. And you have to remember there are actually blood vessels, so be careful with how the rectus sheath obviously does not extend below the umbilicus, so there's no posterior rectus sheath. So rectus abdominis block is only from the zippy to the umbilicus. That's where it will mostly cover it. Beyond that, that's how the nerve travels. So it goes anterior to the quadratus lumborum, pierces the transverse abdominis aponeurosis, then travel in the transverse abdominis plane. So that's okay. And you also have to remember that if you want to catch the little cutaneous nerve, you need to be actually posterior. So classical tap might actually miss out the little cutaneous branches. That's important again. Okay, so the more posterior you are with the tap block, the better is your analgesia. This is a point which I was talking about, the Eisenberg point, where you actually go sort of 5 centimeter cranially from the antecephalic spine, and then you go posteriorly in the mid-axillary line, and that's where you would be giving the Eisenberg point for iliohypogastric nerve block. And you have to remember that in the tap block, the L1 can still be spared in 33% of the patients. Okay, so again, blocking posteriorly at the mid-axillary line and posterior point, just above eyelid crest, provides a better cover for the T12L1. Okay. And classical tab block, which was first described by McDonald and his team, that's the Pettis triangle, was probably what we are actually talking about here. Okay. And like I said, the posterior tab is just going through the transverse abdominis aponeurosis and depositing local anesthetic under it. That is a quadratus lumborum 1 block. And it provides a better analgesia and better spread. So the spread is more extensive with this block than with yeah. Coming to the rectus sheath, you can actually give 4-quadrant blocks. In 4-quadrant blocks, you actually give injection below the costal margin, then above the iliac crest. Okay, so that's the 4-quadrant actually tap block. Or and similarly, you can have 4-point rectus sheath blocks. So like you actually have the 6 packs, you divide it into 4 parts and deposit local anesthetic at 2 points. Now you know that there are tendinous intersections. So when you deposit local anesthetic above the posterior rectus sheath, it may not spread evenly. Unlike in children, in adults, it doesn't spread. So giving 4-point blocks actually works better. And this is just demonstrating how that is the tendinous intersections which can actually prevent. They are actually attached to the posterior rectus sheath, um, and they may not actually allow the local anesthetic to actually spread. And the posterior rectus sheath does not extend beyond arcuate line, which usually lies just below the umbilicus. So below the umbilicus, there's no point in doing a posterior rectus sheath block. Okay. This I've already explained that you need to go through the rectus abdominis and deposit local anesthetic over the posterior rectus sheath. So this is an incision. This is a classical incision for the open cholecystectomy or Cocker's incision. So in this case, you can actually combine the upper unilateral rectus sheath block and tap block just under the costal margin, and this covers the Cocker's incision quite well. And this is a midline laparotomy incision. Again, here you can cover the top incision by rectus sheath block. So this is where the rectus sheath catheters are placed by the surgeons. But the lower part below the umbilicus will only be covered by the tap block. It won't be covered by the your rectus sheath block. Below the umbilicus incision can be covered partly with paraumbilical block if it extends above the umbilicus, and classical tap block. Okay. Now, fenestrel incision used for the cesarean section. This is actually best blocked by doing a bilateral ilioinguinal ilioepigastric block rather than classical tap block. So 5 centimeter cranial to the antesupplex spine, and they go posteriorly and in the 5 centimeter. And if you do a tap block at that point, that is the Aschenberger point, and that actually blocks the ilioinguinal ilioepigastric nerves more consistently for this incision. Okay. Sometimes people do vertical paramedial incision, not as common now, but that would just to show that in that case, you just have to do one-sided rectus sheath and tap block. Okay. Your surgery for appendectomy, so McBurney point. Open inguinal hernia surgery, ilioinguinal, I've already explained this, ilioinguinal ilioepigastric in the tap plane at Aschenberger point. And classical tap has much higher para-umbilical hernias, you can do para-umbilicus rectus sheath block, so you can actually come from the top and inject local anesthetic on either side, or you can actually, depends how you actually place your probe, you can do rectus sheath blocks for them. This is a Mercedes-Benz incision, and here you will have to combine rectus sheath and tap block. These kind of incisions are actually used for pancreatectomy, and that's why rectus sheath block alone don't actually provide you analgesia. You can use rectus spinal blocks at say T8 because the incision usually covers just 4/7, T6 to T10, and it will provide you good block for that. Okay. Again, vertical upper para-abdominal, paramedial incisions sometimes are used for patients like for DU perf. Again, you can use rectus sheath blocks for that. Laparoscopic hysterectomies or laparoscopy-assisted hysterectomies, or this I think I've already discovered standard laparoscopic incision. So we do bilateral rectus sheath block and right-sided tap block under the costal margin. So that is for the laparoscopic standard ones. And this is, I think, is the lap-assisted incisions, lap-assisted laparoscopic incision. So in this, most of the time, you can actually, there is a port just around the umbilicus, so you do a parambilical rectus sheath block and do bilateral tap block for laparoscopic hernias or laparoscopic-assisted hysterectomies. So coming to the end of the lecture, so pain control is tailored to patient needs and type of surgery. If the surgery pain is going to last for a long time, and then you need to ensure that the analgesia is provided for that duration time. Some surgeries like, lumps and bumps, or doing some incisions for taking out, non-bony kind of surgeries. And the pain will not last for that long. It's just mild to moderate pain. But if you're actually doing more complex surgeries, then your analgesia has to be catered to that. And we no longer talk about preemptive analgesia, where the analgesia was given even before, like putting epidurals or spinals before. It's more of preventive analgesia. So you do actually give analgesia before the surgical insert, but you also give analgesia throughout the procedure. Okay, so combining regional anesthesia and multimodal anesthesia technique in various combinations is important for that. For abdominal thoracic surgery, you have to understand that it's not just the somatic pain, unlike in orthopedic surgery. It's both somatic as well as visceral pain. So when you are actually using abdominal blocks or interfacial blocks, they are only providing you somatic pain. They're not providing the pain for visceral components. And there where the multimodal analgesia comes in, dexamethasone, diclofenac, magnesium sulfate, clonidine, ketamine, all these all come useful for preventing visceral pain. They obviously actually help in somatic pain as well, but they also help in multimodal analgesia. And again, we're not saying that you should not be using opioids, but use it so multimodal analgesia will reduce the requirements for opioids and thus prevent the side effects which are associated with use of opioids. Okay. Thank you. And I will stop sharing and take some questions from you guys, if there is any. Yes, Rian, Natasha, any one of you you can come on the video if you like, and if there's any questions, you can actually ask me.
No, I've got no questions. That was great. Thank you.
I cleared everything. I think covered most of the which we will likely. Oh, Rian hasn't got a microphone. Anyway, I will actually post the link of the YouTube channel I use. And if you want to watch it again, or if there are any more questions. I mean, I've not actually gone into too much of details. There is actually quite a bit of literature. There is a move towards opioid-free anesthesia. They call it OFA. But remember, OFA does not mean that you can't use opiates in the post-operative period. Okay? Every patient, irrespective of what kind of surgery or even if you had given the best of blocks, you will see I always prescribe opiates for them in the post-operative period. No patient should actually go to the ward with pain, and no patient should go to the ward without prescription for post-operative regular analgesia and for post-op nausea and vomiting. So that's the main I think take-home message for today. Okay, since there are no questions, then we can end this session. And thank